Hello, everyone. Thank you for joining in. And so what we're going to do today is a tissue graft on the upper left canine and the upper left premolar. So the US system 11 and 12. The patient has gingival recession and mucogingival defects in this area. So we want to augment the tissue. And the planned procedure is to do a tunneling procedure through the sulcus, and then using allograftic material, the Osteogenics Microderm. So the patient's already pre-numbed. We gave him some lidocaine and some Marcaine, and we're ready to go. So, thank you. Okay, are we live?
Yep.
Okay, so as you can see, the canine and the premolar have the recession. The premolar is about a 2 to 3 millimeter recession, and the canine is about 4 to 5. And if we look at the amount of keratinized tissue left, so if I pull down, this is the mucogingival junction right there. We have about a couple of millimeters of keratinized tissue left. So this is an ideal case to use a dermal matrix, because this keratinized tissue will be transposed over the roots over here. So my plan is to make an incision going through the sulcus and then to release this so we can get a coronal advancement, and then we'll go ahead and put the tissue through the sulcus and suture it. So like I said, the patient's already numb, and we can go ahead and get started. So the first step is the root preparation. So we're just using a curette to remove the soft dentin and cementum that's exposed. So my recommendation is just to remove enough of this soft material that's built up on the roots. But I don't go overboard with this. Now, sometimes if the root is too prominent, I might use a rotary instrument to flatten the root. But in this case, the root already has a fairly flat profile. So we're just removing some of that, like I said, soft cementum and dentin that's been exposed. We'll do the same thing on the premolar. Wipe. And then the back action, please. All right, and then what I also find useful is this Rhodes chisel, or also called the back action. It allows me to really put it flat against the root to remove that material and flatten the root a little bit just by hand instruments. Okay, saline. All right, so now we're going to irrigate and remove all the blood off the roots. And then we're going to condition the root with Straumann's Graft gel, which is basically a 24% EDTA material. So here it is, and in the show notes we'll put links to all of these products. So this is the EDTA, and what it does, it removes the smear layer off the root, also opens up the collagen fibrils to allow for reattachment. I just want to make sure that we get it all around, and now we got to give it about another minute and a half, and then we go ahead and wash it off. Doing okay? Mm-hmm. Good. Good. So now the root conditioning is completed. Now I'm going to go ahead and apply a little bit of the Straumann Emdogain. So Emdogain is enamel matrix derivative. You can see it here. And it's probably the most studied biologic in dentistry with a very proven track record. So what it does is it upregulates angiogenesis, it tampons down the inflammation post-surgery, it promotes fibroblast differentiation. So overall, it's a wonderful addition to any soft tissue procedures that I do, and it's basically anytime I do a soft tissue procedure, I always use Emdogain. All right, so now we're going to go ahead and prepare our tunnel. So for this, I'm using a microblade instrument that allows me to gently elevate these tissues away. So I like to start the incision at the thickest part of the flap, which is usually the papilla, right at the line angles. So we gently insert, and I'm going right to bone at this level. And then we do the other side. Good suction here. Now the Emdogain precipitates on the root, so even if it gets washed away, the proteins now are on the root, and that root is an active surface. So that's one of the beauties of it, is that it's almost like a time release biologic. Good. The next thing is we're going to use a papilla elevator that allows me to separate this tissue from the underlying bone. This specific one is designed by Professors Otto Zuhr and Hertzler. So the trick here is you want to go under the tissue. Can you see? Yes. Okay. So what we want to do is we don't want to just push this apically. You want to go under the tissue and use almost like a crowbar motion. So you're elevating this way. And then we do that all the way around the tooth to create that pouch. So yeah, this is the upper left is kind of tricky. I always get my hand in the way. Can you see?
A little bit, yes. We can see that.
Okay, so as you can see, I'm just gently lifting away. And then I work my way distal towards tooth number 12. Again, as you see, I'm just like lifting that tissue away from the bone until I make my this almost to this side. Then I will start doing the same thing on the premolar. Okay, now when I go past the mucogingival junction, which is at this level right here, what we do at that point is we're just gently separating the muscle attachment from the bone. So I'm leaving the periosteum intact. So it's mostly full thickness in this area, and above the mucogingival junction, it's a partial thickness elevation. And that's what allows us to release the tissue and move it coronally. How are we doing, Leon? You all good? Okay, so this process is, takes a little time because we want to make sure that the tissue has minimal trauma during this. And as you see, at all times, I have a very firm fulcrum. This is not something you want to freehand, because if you slip, we can traumatize the tissue or cause a perforation. So just gentle, you got to take your time. There's no shortcuts here. So these are the muscle attachments that you can see I'm trying to release. Okay. Better?
Yes.
All right. So you can see the papilla extend, the papilla elevator extends all the way to here now. You see that, and then it goes all the way to the distal of number 12 and the mesial of number 11. So I'm just going to elevate this a little bit more. Okay. All right. So even though we've released it here, I have some release, but it's still not completely passive. So next thing I'm going to do, go ahead, irrigate a little bit so we can show this better. So you can see how we've already corneal advanced it fairly well, but it's still not as passive as I want over here. So the next thing I'm going to do is we'll use our microblade once more, and then very gently release those muscle attachments. And you can see how it like snags on one and then it releases. See how it snags, and then as you cut through it, it releases. So it's a very, very gentle process, and we're going parallel to bone. Okay. So now that allows pretty full release over here. And if I put my probe through on this side, see how it comes out to the other side, and then it extends to the distal of the premolar, and on this side it extends about 6 millimeters mesial to the canine, and again, pretty passive advancement of the tissue. The only thing I'm going to do is release this papilla a little bit here. I need the rabbit's foot. There we go. Alright, for that we're going to use this instrument that's made by Dr. Kern. He calls it the rabbit's foot. So, can you see? Yeah. It allows me to get under the papilla, and then by turning it, I can release that papilla so we don't get that fold in that area there. And again, you got to be careful because the whole idea is that we don't want to cut through that papilla. So, got to be a very gentle elevation here. Okay. Now we got what we wanted. Okay. So next we're going to prepare the tissue so we can place it underneath. So this is about 20 millimeters or so in length, and the width I'm going to go for is about 5 millimeters because that's about the width that we can get in through the sulcus. So we'll need the camera to show over here. Okay. I'll need the Microderm.
Yeah, not yet. Very soon.
Did we want to show it?
Yeah.
Okay, and then just for camera, can I just?
Yeah, one second. All right, so this is the material we're using. It's made by Osteogenics. It's the Cytoplast Microderm. So the beauty of this product is, and I'll show it to you, it's micro-textured. So it allows for revascularization or quicker revascularization. So it heals quicker than the normal allograft material. So, can you see there? So that's the material, and then as you can see, it's got these micro textures on the surface. And it's fairly firm, and that's kind of how I like to place it, is when it's not hydrated, because if you hydrate it, sometimes it gets a little too malleable, and it becomes a little bit more difficult to position. So I'm going to cut it dry, and then I'm going to place it in dry. Okay. So, like I said, this is about a 10 millimeter length tissue. So if we cut it in half, we're going to get a 5 millimeter strip.
Would you like a spatula?
I think this is okay. Give me the scissors too. So you see it's got, it's quite rigid the way it is. There we go, got it, okay. All right, so that's the tissue I'm going to use. And just gonna round the edge a little bit just to make it easier for me to insert it into the, through the sulcus. Okay, so there's the tissue. Let's just show it. Okay. All right, let's go back.
All in one?
Yeah.
Nice.
Oh. Okay. Okay. Next, what I'm going to do is position the tissue, and I like to use a traction suture. And the one that I like is the Glycolone, the 5.0. The 5.0 gives me a little bit more oomph, so to speak. It's got, you know, definitely more resistant to it than a 6.0, so I feel more confident when I pull the graft. And I like this needle that's 18 millimeters because I can navigate through the papilla much easier with this. Okay. You have the blue castor also? Yeah, great. Okay, so what we're going to do is we're going to pull the tissue through here and anchor it over here. So what I'm going to do is, it's going to be kind of tricky to show. It shows?
No, can't do nothing.
And
Yeah, it's going to be, alright, so we'll just go like this. Alright, so I'm going to be anchoring it right there. And I'm going to go through the tissue and come out the sulcus like that. And as you can see, this needle is a black needle, so it makes it a lot easier to see. You see how that contrasts against the tissue. Alright, so now we gotta move our way to here. So I like to back the needle through. If you use the sharp point, sometimes it snags on some loose tissue, and then it doesn't allow the graft to move in easily. So now we're ready to put the graft in. I'm just going to put a clamp on the back end of the suture so it doesn't slip through. There we go. Okay. All right. Yeah. Okay, does this show on camera?
You have to get closer, maybe.
All right.
Can we show the?
yes.
Okay, so we're going to grab the edge with these corn pliers and then go through it with the suture. And if you see, I come from the outside in. You don't want to come the other way. It makes positioning this tissue a lot easier. Okay, so there we go. Good. And now what we're going to do is back the suture, back it out again. This way. And then go back and out over here, so that's where we're going to anchor the graft. That wasn't supposed to happen. Okay, now we got it. Okay. Alright, so I'm pulling on the suture here. My clamp is kind of holding the other end, and I'm going to have my assistant hold it. And then we're just going to gently push the tissue in as I'm tugging on the suture on the other end, and this is going to work its way all the way to the other side. Okay. All right, let's wet it just a little bit. go. Alright, so I'm gonna tuck this part in and just leave this outside edge exposed. I'm gonna tie this side to over here too. So I'm gonna anchor this side over here. So it'll be anchored on both sides. So the tissue is extending now all the way from the mesial line angle of the canine all the way to the distal line angle of the premolar. Alright, so we're just going to do a simple interrupted suture over here. Okay. Good. Okay, now I'm going to switch over to the 6.0, can we say this? Yeah, the 6.0 glycolon with the 13 millimeter needle to do my sling sutures. Let's see. Alright, so I go and the distal line angle, and I'm trying not to grab the tissue. I'm just going under. So I'm going under the flap over the tissue. Okay, go ahead, open for me, please. Open, thank you. Okay, and then we grab the needle and sling it around. Hold this. Good. All right, and then we back it out. The mesial hand. Okay, now in order to also tack this down over here, anchor it over here, so what I'm going to do is go through the tissue here. And now I'm going under the flap, and we're going to exit at the mesial line angle here. Okay, as you see, now when we push this in, okay, then I'm going to go through the papilla that anchors it, and it allows me to coronally advance the flap, and it doesn't put too much pressure on the facial part of the flap. Like that, and then on the palatal, I'm also going through the distal papilla and coming out this way. so this is going to allow me to coronally advance this tissue now. Suction. Okay, got it. Good. All right, and then we're going to do another sling suture over here. Same thing, so we're going to go around. Okay, we go from the inside, grabbing that tissue and the flap, and then come out. And then go through the papilla on the buccal. The mirror. And then we go through the distal papilla on the palatal side. And come out through the buccal and tie it. Right, so I want to coronally advance this a little bit more, so I'm going to do one more suture through that. And then we'll be done. Okay, so because we didn't have to harvest tissue from the palate, the surgery is, goes pretty relatively quickly, and the healing is going to be very easy for the patient and uneventful. Because we used Emdogain and a gentle surgical technique, there's not going to be a lot of swelling or post-op discomfort. So as you can see, the root is 100% covered. What we see here is just a little shading difference in the enamel. But we got 100% coverage, and we also thickened this whole segment of tissue, so that's going to prevent further recession. These sutures will be left in for about at least anywhere from 14 to 20 days. These are absorbable sutures, but we usually end up taking them out at about day 20 because it typically takes about 30 to 35 days for them to completely disappear. So, but they're very non-irritating, so they could stay around for a long time and patients never complain about them. So that's it. We are done with the surgery. Thank you everybody for tuning in, and we'll see you next time. I'm going to put a little bit more Emdogain. I'm just applying a little bit more Emdogain on the top. Yeah. Okay. All right. So as you saw, if you use a very predictable workflow, we can get these procedures done. It took like maybe less than 40 minutes for this, especially because we weren't harvesting from the palate. That usually adds another 10-15 minutes for the harvesting and the trimming and the suturing of the palate. So this makes it very predictable and very easy. And I think our patient did really well. He fell asleep. Yeah, he's great. So thank you again, and we'll see you next time.